And you are on.
Right there. Well, it looks like we're live. Welcome, everybody. My name is Joshua Steere. I'm an orthopedic surgeon here at Bucks County Orthopedic Specialists. I'd like to welcome everyone. This is our second of several Ask the Doc segments, and so we hope you were able to see Dr. Park in his conversation about carpal tunnel syndrome, and we have several others to follow this one. I specialize in hip and knee replacements, and so this session is going to be focusing on knee pain and ways that we can non-operatively manage and help reduce knee pain, specifically for, or mostly for things like osteoarthritis, but also for other conditions. I'd like to start by saying I hope everyone who's watching this is safe and that your families are safe. This coronavirus pandemic has affected all of us in different ways. I think we can get through this together if we all do our part to help mitigate the spread of the disease, hand washing, social distancing. We have masks here in the office I'd normally be wearing if I'm not speaking with you. So my background is in orthopedic surgery. I did a fellowship specializing in hip and knee replacement at Stanford University in California. Before that, I did my orthopedic training at the University of Pennsylvania, or Penn, in Philadelphia, locally. I focus my practice on hip and knee replacement, mostly for conditions like osteoarthritis, but also other conditions like dysplasia, rheumatoid arthritis, and other problems like that. A lot of my patients and a lot of our patients here at Bucks County Orthopedic Specialists have been affected by the coronavirus pandemic, either by having their care delayed or difficulty having inpatient appointments. We hope this is a way to stay connected with all of you. So before I get into the specific questions, I'd like to go through some of the most common questions that I'm asked in clinic when I see someone with knee pain. And you know, there are many different things that can cause pain in the knee. They can either be chronic, meaning they've been going on for a long period of time. They can be acute, you know, an injury that just happened recently. My focus tends to be on osteoarthritis, which is more of a chronic condition. Osteoarthritis is a condition where the cartilage caps on the end of the bones, these cartilage caps act as a shock absorber for the knee, so that when you walk, you're walking pain-free with smooth motion. And if that cartilage cap wears down over time, then you get friction between the bones. And if that cartilage cap wears down all the way, it can end up being bone on bone and be quite painful. One of the things that's unique about the knee is that pain is often a combination of factors. So there's a mechanical factor. And one way I think of it is if you're outside and you get some dust that blows in your eye, you get pain from the dust and the particles in your eye, but then what you get is an inflammatory response, which is the swelling, the tearing up, the redness. And so even after you clean out the dust particles, you still have that lingering pain, and that's the inflammation. And with knee arthritis, the pain tends to come from both the mechanical injury as well as the inflammation. So it's a biologic response to the arthritis. And a lot of the efforts to minimize knee pain non-operatively are efforts to reduce this inflammatory response. You can also think of it like if you eat spicy food. You haven't injured your mouth, but it's painful and it's swollen. And so a lot of the efforts to reduce the inflammation are to mitigate the pain or to reduce the inflammation. So the first step I often talk about are the non-operative treatments. You know, the final treatment for people with knee arthritis can be a joint replacement, but there's many things we can do that are non-operative. I prefer not to use the term conservative treatment because a lot of times I think that implies that sometimes we're not doing everything that we can. in my view, I think we should focus on the treatment that is going to be the most effective. And a lot of times it is non-operative treatment. And so, our academy has published guidelines based on analysis of studies of different treatments for knee arthritis. And based on those guidelines, we were able to recommend certain treatments over others. So starting with the treatments that have the best evidence in terms of helping knee pain, specifically from arthritis, one of the best things is low impact aerobic exercise. And what that means is low impact are things like doing the stationary bike or cycling, the elliptical trainer, which is more of a cross-country type skiing motion. Swimming is also a good low impact exercise. And these exercises done for 15, 20, 30 minutes to a point where it gets your heart rate up. Your body releases a lot of natural endorphins, and you get a lot of blood flow to your legs and to your body. And low impact exercise has been found to be very effective in helping people with knee arthritis. And it can be counterintuitive because you think if the knee is painful that you want to rest it. But what happens is when you do these exercises is you strengthen and build up the endurance in the muscles around the knee. You help take some of the tension out of the joint, meaning if the knee is tight and the ligaments are tight, by doing the exercise, it kind of helps take the tension out of the joint. The other thing it does is it strengthens up the muscles around the knee. It strengthens up the low back muscles, the core muscles, the hip muscles, so that you're able to use these other joints to help offload the knee. So the first thing I recommend to a lot of patients is to start with some low impact exercise. And whether that's at a gym or in the home, it depends on what kind of access you have, but that can be very helpful. One of the questions that was submitted and often goes with this is physical therapy. So we work closely with our physical therapy colleagues to help patients who have knee pain, because a lot of times it's not just the knee. A lot of times people have some weakness in the core. A lot of times they have some weakness in the hips. And when that happens, we tend to overload the knee joints. So if you're going up and down the stairs, you can either kind of push your weight through the knee, or you can use your glutes and your back to kind of help get you up the stairs. And what often is the case is that we tend to overload the knees and rely on them more. And oftentimes a therapist can look at the way that you walk and the way that you move, and can help find ways to reduce the load on a painful joint. And so that's where, and the physical therapist can also take you through exercises and some stretches that can help take the tension out of the joint, so that as the knee is moving, that you don't have as much friction between the joint surfaces. So low impact exercise, physical therapy, and then it's the other part of the equation is taking the right kind of medications. And so I spent a lot of time talking with patients about, what are the right types of medicines to take, and what's a safe way to take them. So the type of medication that's been found to work the best for joint pain related to arthritis are medicines called NSAIDs, or non-steroidal anti-inflammatory medications. And these include medicines like ibuprofen, Aleve, or naproxen. There are some prescription strength medicines called meloxicam or Celebrex. So these are all good medicines to help with arthritis. They're safe for many people to take, but there are some people who, for either medical reasons or different reasons, shouldn't be taking them. So that's a conversation with your doctor. For people who, and I think this was one of the other questions, is what options do I have if I can't take anti-inflammatory medications? So there are sometimes these are available in a topical form, meaning rather than taking them in pill form, and you can take them as a pill and apply the medication directly to the knee, or for someone who's elbow pain, apply it to the skin, and it works transcutaneously. So that is an alternative for people that can't take the NSAID pills. So NSAIDs kind of are one class of medication. The other two classes of medications in general sense, the other is Tylenol. Tylenol is separate from medicines like ibuprofen. And Tylenol can be helpful. It doesn't have as strong of an effect on the joint. And then the last the last class are the opiates, things like oxycodone and Vicodin. These have actually been shown not to be very effective for joint pain. And the reason is they really don't affect the inflammation in the joint. I mentioned at the beginning the analogy of getting dust and debris in your eye. In arthritis, what happens is not only does the cartilage wear down, but you get a biologic and an inflammatory response inside the knee. And the lining of the knee, called the synovium, detects that something mechanically is off, and it creates the inflammation. And so where the NSAIDs are especially helpful is that they help reduce that inflammatory response. And so it doesn't necessarily change the mechanical wear in the knee, but it does reduce the inflammation. And a lot of times it's that inflammation that's painful. So we talked about the exercises, the low-impact exercises, anti-inflammatory medications. And the other part of the coin is weight loss, or broadly speaking, kind of stress reduction on the joint. So for every extra 5 pounds of weight that we're carrying, that puts about 5 to 7 times our weight on the knee. And so, if you think about if you have knee pain, what it would feel like to walk around carrying a 10-pound backpack, it can have a pretty significant difference, and especially activities like going up and down the stairs. And, weight loss is difficult. It's challenging. There's really not a silver bullet to fix that. But what's encouraging is that even small amounts of weight loss can have a big impact. So, your body sees 5 to 7 times your body weight. So losing 5 pounds is kind of like taking 25 pounds off of the knee joint. And that can make a big difference. And so even small incremental changes over time, it doesn't have to be, losing, a lot of weight all at once. It's the healthy small incremental changes can make a big difference. And so we work closely with colleagues in this community who can help counsel our patients and kind of strategize ways to help this. Part of the stress reduction aspect, in addition to reducing the body weight, is changing the way we do certain activities. I mentioned the therapist can help look at the way you're walking and moving, and there may be ways to change some of the aggravating activities. We call that activity modification. In addition to that, sometimes using an assisted device like a cane, or even for short periods of time, a walker can help offload the knee. So that in general terms are some of the non-operative treatments that can help alleviate the knee pain. So let me turn to a couple of the specific questions. Michelle asks, what are your thoughts on taking supplements that can help decrease inflammation and pain? Things like omega-3, turmeric, glucosamine, or chondroitin. So this is a very good question. I get this question a lot from patients. The supplements, I think the jury is still out on a lot of the supplements. And I say that meaning there are, for each of these, there are some small studies, some small comparison studies that do show some benefit. I think each of these supplements has to be taken individually or looked at individually because they do act differently. And I think one of the concerns with some of the supplements is that without larger comparison studies, it's hard for me to really recommend a certain dose because we just don't know. For turmeric, for example, anecdotally, I know people who take turmeric and have gotten benefit from it. The studies on it seem to indicate it acts similarly to a medicine like ibuprofen or another anti-inflammatory. But it's hard to know what dose is safe because they haven't done the same rigorous studies that they have for the other medicines. And so I don't routinely recommend supplements. But that being said, if a patient comes in and they're taking them safely and they find that it's helping them, I'm happy to recommend that they continue using them so long as it's not overly expensive or if the supplement has a reaction with some of their other medications. Glucosamine and chondroitin, we had a lot of hope that would be kind of a game changer in treating arthritis. What some of the studies have found is that when they compare it to taking a placebo, that it doesn't provide that much of a difference in benefit. So we don't routinely recommend that, but it's the same thing. If someone is taking it, and if for them as an individual is providing a benefit, then I'm happy to have that to continue that. Another question came in from Joseph, asks, what about back pain going into the left hip and down the leg? So this is a good point. So there are other things that can cause pain in the knee that aren't necessarily coming from the knee joint. So sometimes we see patients who have hip arthritis, and by the way the nerves in the leg work, that hip arthritis creates the sensation of knee pain. Similar, I think of it, if you hit your funny bone in your elbow, you feel the pain in the fingers even though you hit your elbow. And so if you tend to feel the pain where the nerve travels to. So some people with hip pain or with back pain, if there's a pinched nerve in the back, that can cause pain that travels down the leg to the knee joint. And so one of the things when you visit with your doctor or your surgeon is to try to make sure that the pain that we're treating is coming from the knee joint versus the hip or the back. So that's a very good question. The next question says, I read recently that this is a medication called Steere. Clinical studies have shown increased cartilage thickness. I actually had to look this up. So Steere is a medication that's currently in clinical trials with the FDA. It's they just published their stage 2. This I'll kind of put in the category of biologic injections. I think there's a lot of hope that one day we find a way to biologically trigger the cartilage cells that are on the ends of the bones to grow more cartilage. It's been a big challenge. A lot of scientists have looked at ways to grow cartilage. There are a few, except in rare circumstances, there isn't a technique or a way right now to kind of replace the cartilage that's worn down in the knee. It's something that a lot of people are working on, both in industry and in academia, to try to study and see if they can unlock kind of the secret to how to get cartilage to grow. But when people who study cartilage look at cartilage, the structure of cartilage is very complicated. It's a 3-dimensional kind of interwoven network of collagen fibers, and the different layers have different orientations. And so it's been a big challenge. But our hope is that one day there's a biologic treatment. Right now you'll see advertisements for things like platelet-rich plasma, which is referred to as PRP. There are some, mesenchymal stem cells, or what people are calling sometimes stem cells. Right now, I think those are still in the early experimental phase, and I think right now a lot of those are focusing on the inflammation aspect of arthritis. As of yet, there isn't a good product that can rebuild the cartilage. In the study that for the Steere specifically, it did increase cartilage thickness. It was by about 0.05 millimeters. And so that's hopefully we continue to see kind of larger growth. It's unclear how much of a clinical impact that'll have if adding that small amount of cartilage will change someone's symptoms. I think that's really the question. That's a good question. So I think the jury's still out. I think as people work hard to research these techniques, I think hopefully we'll have something down the road that we can provide. A question from Caroline says, when you need a knee scope, what exactly is being done? How long does that last? And does it often lead to knee replacement in the future? So knee arthroscopy is a surgical technique where you look inside the knee with a camera. It's a small camera, about 3 millimeters, and you can look inside the joint and see if there's mechanical damage or other inflammation. Not everyone who needs a knee arthroscopy, hopefully most people don't, need to go on to having a knee replacement. The procedure length, it depends on what the procedure is. Most commonly, it's to look at the meniscus and see if there's a tear in the meniscus. Sometimes if you have a tear in the meniscus, it kind of behaves like if you have a tear in your fingernail where the torn piece is getting caught. And if you trim it back to a smooth surface, then it alleviates the pain. So that's what knee arthroscopy is. And the next couple of questions talk about surgeries. Rachel asks, she says that she knows someone who had what's called a plica, removed with arthroscopic surgery, and now the knee is having some popping and some locking, and can the plica grow back? So plica is referred to when the synovium in the knee, the synovium is the lining of the knee joint, similar to how on the inside of your mouth you kind of have this special type of cell that lines the inside of the mouth. Well, the knee has a sort of a similar type lining, and that lining is what makes the joint fluid that lubricates the knee. But what can happen sometimes is some of that lining can fold on itself and create essentially a thick band. And if that thick band is rubbing against the bone, that can certainly cause pain and discomfort. It's pretty uncommon for a plica to lead to symptoms, but sometimes going in and trimming down that plica is what's needed. As far as what's causing persistent symptoms, certainly in some cases a plica can come back. It's rare. I think it's about 18 to 20% of times a plica can come back. To answer that question, though, it would really require an in-person exam to say for sure what's going on, because there certainly are other things that can cause discomfort in the knee other than the plica. This is sort of similar to Lori's question. Lori asks, I was diagnosed with a condition called synovial chondromatosis, which I'll explain, in my knee, and I had an arthroscopic procedure to remove the loose bodies in the bursa. Since the procedure, I've had some persistent pain without swelling. Is there anything you suggest I can do? So synovial chondromatosis is sort of an uncommon condition where the lining of the knee joint creates these little cartilage nodules, and sometimes it can make a lot of them, and so many that they kind of get caught in the joint. And sometimes what we need to do is go in and remove those cartilage nodules so they're not getting stuck in the joint and causing problems. In some cases that can come back. It's rare. Again, like it's maybe about 15 to 20%. It's not a common condition to have in the knee. As to why the knee is still painful, it's kind of hard to say in this context. There certainly can be a number of reasons. I think the best thing to do would be either to make an appointment or to follow up with your initial surgeon to kind of see potentially if they came back, or it could be that you're having some residual inflammation. And so if that's the case, certainly what you could try is low impact exercises, like I mentioned before, anti-inflammatory medications if they're safe. But to recommend much more beyond that, it would be best to look at the knee and to do an exam. And then the last question we had, and then we'll get to the new questions. Rachel said, unfortunately, I had my knee replaced almost 3 years ago, and I still have pain. What can I do? I'm sorry to hear this, Rachel. That is one of the most difficult questions that I have to look at, is if someone has had a knee replacement and are still having symptoms. It's definitely hard to say without seeing the x-rays and seeing your knee. Kind of the algorithm, though, that we look at is first, if someone has had a knee replacement and they're having some pain, is the pain coming from the knee, or is it referred pain? Like I mentioned before, sometimes hip or back issues can lead to discomfort in the area of the knee. And then the second branch point is looking at, is the pain coming from the replacement, or is it coming from some of the tissues or ligaments or tendons or muscles that are around the knee but outside the joint? And a lot of times that can be the case. But to say more definitively or to recommend a treatment, I'd be happy to meet with you in person and to go through that. But most of the time, there are things that we can do to help someone with discomfort in the knee after a knee replacement that are non-operative. And so that I will say that as a point of hopefully encouragement. So let me move to some of the questions that have come up since we got started here. This one's from Greg. Tell me about autologous chondrocyte implantation. So what that means, this is a procedure where cartilage, if someone has a focal defect in the cartilage on the knee joint, and I say focal because a lot of times when someone has knee arthritis, it's kind of the whole surface is worn down. think of it like the entire lane of the highway has been excavated, and so the whole lane is out. What chondrocyte implantation can be used to treat is if there's a little pothole. If someone had a specific injury, an osteochondral defect, if someone has a focal injury right now, they're working on developing treatments to potentially replace just that small pothole. So the first thing I'll say about autologous chondrocyte implantation is that the indications are quite narrow, meaning most people with arthritis are not going to be good candidates for this. The people who are good candidates for that surgery are people who have a focal lesion without a lot of arthritis in other parts of the knee. And what's done in that surgery is it's a two-step operation. Oftentimes, there's different commercial variations of this, but a lot of times you take some of the cartilage cells from the knee in a place that's not weight-bearing. They're sent to a lab, and they're used to try to grow some of your own cartilage tissue from your own cells. And then those are put back into the knee, into that focal deficit, and to try to replace the cartilage that's been missing. So that's what that procedure is. In a lot of ways, it's still in the experimental phases. There are regional experts who do a lot of this. Dr. James Carey, for example, at University of Pennsylvania, I worked with him, and he does a lot of these procedures and is a national expert. So let's see, the next question is... So Connie M. asks about, what about medical marijuana? So I would say, like a lot of the other supplements, the jury is still out, I think. We as a medical community haven't really been able to study it very effectively because of both federal and state restrictions on studying medical marijuana. Anecdotally, some people have said that it's been helpful. I've heard others say not. So it's, without doing a large study, it's kind of hard to say how effective it is. One thing I do caution patients on is there are some commercial CBD products that can be quite expensive. We don't really have a good understanding how that works and how much, what dosing is needed. So in a state like Pennsylvania, where marijuana is not legal, the amount of CBD in the lotion, it's widely variable. There's not a lot of regulation on it. And so compared to another state like California or Colorado, where at least from a state level, some use is permitted, the concentrations are maybe higher. And so it's really kind of, I have a hard time recommending one way or the other because I don't know the science behind it. So, or we haven't just done the studies. So that I can't give a strong recommendation for. But potentially in the future, it may show itself to be an effective treatment. I just don't know. So is running bad? This is, sorry, from Elena. Is running bad for my knee if I have arthritis? So this is a good question. So it's been controversial whether or not running is bad for the knees in general. I tend to think not. I think that exercise is good for the knees. I will say, though, that once there's damage in the knee, I think once there's arthritis or once there's some other mechanical issue in the knee, running can be difficult because running, what I say is, it asks the most of our knee. It's probably the most strenuous thing that we do other than, heavy weightlifting. But for my patients who enjoy running, who have knee pain, a lot of times especially if they're having acute pain, I'll say, well, let's take a step back and go to some low impact exercises first. The biking, the elliptical, the swimming, because at least you're using the knee, but you're not impact loading every time with your whole body weight coming down on the leg. And what I say is, if we can strengthen up the leg and the hips and maybe have a therapist look at your form and figure out ways to offload the knee, that if you're able to do the low impact exercises, the bike, the elliptical, and you're able to do that relatively pain-free, meaning, the next 3 days you're not having agonizing pain. If you're able to do that, then try to go back to running and start with about half as much as you think you can do. So if you think, you can run a mile, start with a half and see how you feel. But it's not to say that people with arthritis can't run. I know a lot of people who have x-rays that look, like they have very, very advanced arthritis who run a lot. It's an individual thing. And so I don't think that getting diagnosed with arthritis means that you're your running is finished. But I will say it does tend to ask the most of the knee, and that is a common way for the knee to get flared up in people with arthritis. All right, so this question is, how do you determine non-surgical options for someone who is a regular moderate exercise with knee pain? Let me see if I can find. Who's a regular moderate exerciser with knee pain to delay a total joint. So the question of when to have a joint replacement is very individual. And so a lot of times that comes down to how severe the symptoms are and what types of activities are limiting you. And so there's a lot of people who have pretty advanced arthritis, but they're able to do the things that they like to do. The pain isn't severe, and so they live comfortably and happily using a lot of these non-operative treatments. It's once the pain starts to get more severe, for example, if it's waking you up at night, that's very disturbing. And if it's starting to limit more and more activities, so say someone decides to stop running because that's too painful, but they find another activity like pickleball or like swimming, and if they're happy with the way they're doing and are taking anti-inflammatory medications and doing some therapy, a lot of times we can get people to a point where they can do the things they want to do. It's when you cross that line where you feel like you're giving up too much and you feel like your life is getting kind of closed in, meaning leaving the house just to go to the grocery store, for example, is painful. People get to that point where they feel like they're giving up too much and they decide to go forward with surgery. And fortunately, surgery it has excellent results, and so it's a very successful surgery for people that decide to do that. So for people who are regular and moderate exercisers, I'll kind of look at what they've done in the non-operative list and potentially add some things and then see where that gets us and see how the arthritis progresses. But if we're able to get the pain and symptoms under control, then that's ideal. So it looks like we're coming to the end of our time. I'd like to thank everyone who joined. And, I'd just like to say that, right now during the coronavirus pandemic, our office is still open for acute injuries like fractures or concerning things like infections. For a lot of our patients, we're doing telemedicine visits where we use an interface, either like FaceTime or medical software where we can see you in person and do a live one-to-one visit. We can recommend imaging and medications and send you referrals. So we're able to do a lot of the things that we would otherwise do face-to-face in the office. If you're interested in scheduling a telemedicine visit, the number to call us is 215-348-7000, and they can get you set up with any one of our providers. Bucks County Orthopedic Specialist has been in the community for 40 years, serving our community, and we will continue to do so throughout the pandemic and afterwards. And so we offer services in every medical specialty, every orthopedic specialty. And so if you're having any problems or have any questions, please feel free to reach out to us. And so with that, I'll sign off and wish everyone an excellent day and to stay safe and to do your part to help mitigate the spread of this virus. Thank you.
Can you turn it off? You know how to turn it off.